We'll get started with housekeeping items. So welcome everyone. Good afternoon and welcome to today's webinar, Leveraging Health IT for Diabetes, Track, Improve, and Manage Health Outcomes. My name is Rima Naik and I'm the Performance Improvement Manager at Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to healthcare for all, especially the underserved and underinsured populations. For more information, you can visit us at nvpca.org. This training is a partnership between Nevada Primary Care Association, Collaborative Ventures Network Health Center Control Network, and the National Association of Community Health Centers, also known as NAC. I just want to take a moment to thank them for helping us coordinate this session. Before we get started, I would like to go over some logistics and housekeeping items for today's webinar. Please type in your name and organization into the chat box. It is nice to see who in the community is participating in this webinar today. During the presentation, please make sure to mute your phone or computer so that we do not have feedback or background noise. Also, please be sure to put your phone on hold or to not put your phone on hold or we will hear your background music. If you have the opportunity to submit questions to the presenters, you can type it into the question and Q&A box. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of the presentation. Today's session will be recorded and slides will be available to participants. I would now like to introduce today's speakers. Raymond Uy is a physician informaticist working at NAC. He is a visiting professor of health informatics management, teaching medical students and attendings and MBA graduate students at both the Ateneo de Manila University School of Medicine and Public Health and the Ateneo Graduate School of Business in the Philippines. Since completing his postdoctoral fellowship in biomedical informatics at NIH's National Library of Medicine, Dr. Uy has been working as a clinical informatics consultant, assisting resource-limited clinics and health centers, hospitals, academic and industry stakeholders in both the Asia-Pacific region and in the U.S. He's a scientific reviewer for the American Medical Informatics Association and the International Medical Informatics Association, as well as an assessor for the Text Retrieval Conference and NIST and US DoD partnership, contributing to efforts in clinical information retrieval, clinical decision support, and precision medicine. Julia Skapik is the Medical Director of Informatics for NAC and a board-certified internist and clinical informaticist. Dr. Skapik is an industry as a member of the HL7 Board of Directors and Chief Medical Informatics Officer at Logica Health. She's currently a practicing community health provider with Neighborhood Health of Virginia. With that, I will leave it to Dr. Uy and Dr. Skapik to lead today's presentation. Thank you.
Thank you so much to Rima, Lindsay, Brandy, and all of you for joining us today. I'm Julia Skapik, Medical Director for Informatics. We're just pulling up the slides today. We just want to invite all of you as we're getting started here to feel free to reach out to either one of us, not only in regards to health IT for diabetes, but any kind of informatics or technology concerns, ideas, interests that you have. NAC is working on some informatics curriculum that we hope to start rolling out in the near future. And I'm going to tell you a little bit about our human-centered design framework, but the presentation today is kind of the tip of the iceberg, so feel free to engage with us. We do have a link for you to sign up for our informatics site and listserv. So I think we'll get to that at the end. But again, thank you for having us, and you can go ahead and get started, Ray. So today we're going to talk about sort of 4 objectives. We're going to explore strategies for syncing up clinical and data workflows, understand how diabetes data fits into those workflows, identify methods of workflow and waste analysis with lean principles, and distinguish between diabetes clinical care gaps and data care gaps when analyzing patient charts. And I think that distinction is an important one. Your performance may look suboptimal, but much of that may not be clinical performance related, but rather data performance related. One of the approaches that NAC really wants to emphasize is we approach our informatics work from a human-centered design framework, and that's important because it means that the patients and the care team should really be the central focus of how the process is designed and then how the technology is used. Many times people think that they can get technology and technology can somehow fix their broken processes, and that's not true at all. In fact, I would guess that many of you have had the experience where you added technology to a process that was difficult or complex, and you found that that actually made some of your problems worse and created its own set of new challenges. So here we try to approach sort of the QI design using that human-centered design framework, where you engage all of your partners at the outset of whatever you're doing and talk about what is the shared goal. And we encourage everyone to have to come to the table with, being selfish, bring your own goals to the table. And then as a group, you need to say, how do we design the way that we're going to work so actually everyone who's a stakeholder in this process gets something out of it? And, if you're really being forward thinking and leaning, you can even do this and involve patients, right? If you're trying to improve diabetes care, why not ask some patients with diabetes? What do they perceive on their end? One of the things that lean and human-centered design tells us is assumptions about what people are experiencing or how well a process works almost always turn out to be false. And that if we don't go to talk to the people on the ground or actually experience what's happening ourselves, those assumptions will drive our solution off course. So part of making sure that we have those people in the center is to tell the story. NAC is big at telling the health center story sort of to our policymakers, but no one makes that argument better than you yourselves who are in the health center environment. And it can be really impactful actually to tell the story of real patients or prototypical patients to help focus your work. So for example, if one of the stories you tell is a patient who ends up with DKA every 3 months because they don't have a car and they can't get to their pharmacy to refill their meds, that actually should tell you, hey, if we're not tracking patients who have transportation barriers, that could be a limitation to our success in improving diabetes management for these patients. You take the personas, the people you're talking about, and you also describe what is the process sort of at a narrative level. So those are in sort of the informatics term world called use cases often. And while these stories can be really useful in sort of engaging stakeholders with different level of technical and clinical knowledge, you'll find they're also useful on the technology side, as I'll tell you in a minute. Defining the data dictionary, this is both the things that you're already measuring and the things that you want to measure. So if you're not measuring patients who have transportation barriers, we have to build into the solution a way for us both to figure out how do we do that, how do we share that information, how do we test to make sure that it's working. And oftentimes you'll say, well, we have this information because there's a place for it in the record. You don't look at your data also just realize, oh, no one's filling that information, that field out in the record. You won't be able to extract that data. And then finally, after you've sort of done all this background work, then you want to move to a solution. Ray's going to talk about lean and agile a little bit, and it can be very challenging as you're talking about the barriers you're experiencing to jump right to, oh, you know what we should do? We should do this. But we encourage you to not rush to the solution space, but rather, lay the groundwork and take a step back and look at everything at once. And then you'll find that your first solution or first iteration at the solution will avoid some of the pitfalls you might have been trapped by. Next slide. And as I mentioned, while some technically focused people can say, oh, well, writing down a story seems like a silly thing as part of a technology effort, actually, we can use these stories directly to create test documents, to create requirements, and to build solutions. So the personas we build become electronic test cases. And if we include the transportation element in our persona about our diabetes patient, then when we go to test it, we'll make sure that we actually ping that part of the record, or we will reveal if there's a deficiency with that information coming out. The same thing is true of use cases. We use those to define workflows, and those define system logic. And then with the data dictionary, that helps us to learn not only where the data is and how it's moving, but also how do we get it out of the system. Next slide. So I like this 7 stages of the health data life cycle. If you don't sort of walk through all of these before you try to run, if you sort of walk through them before you try to run, you may find that you'll sort of trip and fall into a trap. So, and I think clinicians probably like the baseline EKG kind of way of presenting the information. So steps 1 and 2, finding the data, as we said, this activity can start with sort of literally creating a list of what are all the things that we need to measure, what are the fields that we already know exist in the record, what were the things that we weren't sure if we capture them well that we know that we would need in order to drive parts of our solution. And you want to find where the data is located in the record, keeping in mind that sometimes that's multiple places. Lean tells us that variation is usually waste. So if there's too many places to put information in the record, that actually could be harmful to your effort. However, if there's multiple places in the workflow you can fill in gaps, then it may be helpful. So you just want to be sort of cognizant of how you're integrating the data capture pieces into the workflow. And the capturing the data both refers to having someone input it and also then moving it from the place where it's input into a place where it can be aggregated. Next. That involves normalization. So people are very surprised in other industries, and our patients are often surprised that things like an address are very poorly standardized in healthcare. They seem very straightforward. Even things that should be straightforward, such as lab values, are often challenging. And so being very clear about the fact that you can collect the data any way you want, but when you send the data over, or when you reduce it and aggregate it, it all needs to look the same. We're going to share an exchange definition, and we're going to use that across all of the different sites, all of the different places in the record. So the data always comes out looking the same, and we can easily say, you know, this diabetes definition, this patient has diabetes because all the patients meet the same definition. Next, we move to aggregating that data. Many systems can do this for you. They should do this for you. You may find that your system doesn't do this in the way that you want. Sometimes people will use a third-party product, or they'll also use a data warehouse. And all of you are very fortunate to have health center controlled networks that can help you with this as well. So thinking about, you know, is it necessary for me to aggregate the data, or do I have a partner that can standardize and help me get to that place without having to put in the effort on my end? Reporting the data. So if you've normalized the data well, captured the data well, and then aggregated it uniformly, reporting should be pretty easy. Although what we see in the field is the people who want you to report data are not very thoughtful sometimes, or aware that the definitions they create don't maybe match other reporting definitions you have. So one of the places where NAC would love to help you is if you're finding that there's data harmonization that needs to happen. We have a strong interest in helping to advocate for health centers and reducing some of these unnecessary redefinitions of data that are required for reporting. Understanding the data. So after you have these reports, looking at them and saying, okay, well, does this make sense to us? So one of the things that we discovered in some of our cardiovascular million hertz work is the patients who are most likely to have controlled blood pressure are the patients on no medicines. that doesn't really make sense. Maybe our data pool is being contaminated by people who don't really have hypertension, but somehow they're getting sucked into our denominator. And then acting on the data is important. And from our perspective, not only doing a clinical quality improvement kind of approach to act on that data, but also an informatics quality improvement effort to act on the data, actually validating the data, making sure that it continues to flow, creating stepwise improvements to add in other data sources to help you validate and fill data gaps. Next slide. So these are some examples from the CMS Electronic Clinical Quality Measure Program. I worked with this program from the beginning of Meaningful Use Stage 2 all the way through to the end of it. These measures, they have changed somewhat from year to year, but they at least do provide standardized definitions of which patients should go into the measure, how are the numerators defined, what are reasonable exclusions, and they, of course, include references that you can use to say, you know, this is the science that these measures are based on. Obviously, if you can align your own QI efforts around measures you already have to collect or report, or measures which you may be able to work with payers to get incentive payments on, that's to your advantage because now you're using that data for sort of double duty. There is a movement increasingly in measures to consider bundling or creating what's called composite measures, so that you look not only at the eye exam, but also looking at the foot exam, looking at whether or not the patient is regularly getting the A1C check. You can create the definition of these patients once and then use multiple metrics, so you can actually get a score and see the patient meets 3 criteria but not the 4th, and sort of look at your QI effort in that way. Maybe target even the patients who meet 0 of 4 criteria before you target the ones that meet 3. Next slide. And so these are some good examples, right, of real data of patients in their diabetes control on some of these metrics. And one can guess that when you see things like your performance is 0 or your performance is significantly different than others, those are places you want to investigate first and try to understand why that performance is different. And being able to compare yourself to other organizations can also give you an idea of, what's a reasonable target. Obviously, organizations create benchmarks too that are goals from which you would sometimes get incentive payments. So paying attention to those is important. Next slide. This is another example that compares over time how people are doing. One thing that I think is underutilized in regards to these measures in the field is, instead of waiting till the end of the year to look at our performance, why don't we continuously analyze these measures from week to week or month to month, and we can see where our overall numbers are going up and down and get a sort of better trend. And that helps us to course correct. And Ray's going to talk about the part of the whole reason we're talking about using measures is to help us guide actions that can fill in data gaps and care gaps. And this is Nevada FQHC performance in patients with uncontrolled diabetes. Obviously, the distribution is broad. And again, we find when we look at some of these outliers at the top here that oftentimes the data is not coming in. It's not that no one has controlled diabetes. So those are actually easy pickups because you don't have to do anything different for the patients in order to improve your performance. So as you're creating your data dictionary and looking at your workflow and your data flow, you do really need to understand your metrics and define those metrics. One of the mistakes people make is not selecting metrics early enough so that they can build the data elements they need to capture into the solution process, as well as early on into sort of quality assurance and testing for the baseline. People will often say, okay, well, we'll have a baseline period and we'll start the QI initiative and then we'll look at the baseline measures. Oftentimes, it requires a significant amount of improvement on your data strategy and your measurement process. So what you'll get is actually confusion as to what changes from your quote baseline measures are due to your data improvements and what changes are due to your clinical improvements. So something to think about is actually just spending one QI cycle working on your data before you do any QI cycle around implementing an intervention. And the making sure that you understand sort of who the measure touches is also important. If the medical assistant does all the data entry, then working with the physicians to standardize the data fields probably won't help you much unless the medical assistants are going to somehow be able to enter into those fields in the physician templates. And thinking about actually how you can do quality improvement activities outside of the visit. Most care visits are already overloaded with preventive care activities with the patient's immediate concerns. So if you can take elements of care coordination and care management out of the visit and move them into virtual health settings, move them into care coordination and care planning sessions, or even community health worker calls, you'll find that it's easier to fill those gaps than it is to dump more things into an already brief primary care visit. So I'm going to turn it over to Ray. Ray, thanks so much. And I think you're going to get into the meat of it now.
Yes, thank you so much, Julia. Now that Julia set the stage, really, we're going to go again to the nitty-gritty of things. What you guys saw on these previous slides, again, was really looking at processes or categories of processes, and who are doing those processes and what configurations or what workflow considerations we are thinking of. So what you're seeing right now is a tabulation, like this. So what are the activities that you usually do, for example, for your diabetes patients? As an overlap towards what are your data activities too? Because usually what's happening is you can see what the physical processes happening in the clinics when a person with diabetes enters. They go from A to B to C to D, but then again we sometimes tend to forget that there's this workflow, data workflow that we need to consider too. So what I wanted to show before I dive into more of the mapping and the lean and the agile methodologies is to look at this map right here. It shows one-way, two-way transfers of how data goes around from medical professionals, PHRs, to EMR, to the patient portal, to personal health records for some, to EHR, and all these other stuff to health consumers. And this is very difficult to read because you see a lot of crisscrossing, and because it's not linear or it's not time sensitive. And we want time sensitivity is important because if you want to make sure that you're not wasting your time, or you're not wasting the time of your MA, your nurse, your PA, or your physician, you want to make sure that you're optimizing each and every process or activity. So before that, there is a polling question, Randy. So I want you guys to look at your poll. There's a poll right now. Do you have a clinical process workflow map easily available to view and review? I give you guys about a couple of seconds to say yes or no to that. Go ahead. All right, so I think that's enough time. And what did the poll say? 22% says yes, and the majority, almost 80%, said no. You don't have a clinical process workflow map available to view and review in your clinic. So we're gonna try to change that. We're not, again, prescribing that you guys do it, but I want you guys to think about how these maps can really help. So looking at workflows, the top four icons or kind of boundary boxes that you will see is this oval, which is the start or end of a process, a rectangle, which is an operation or a specific task or activity, a diamond, which is like a decision point for a yes or a no or stuff like that, and then directional arrows. There are some other additional stuff that you will see when you look at clinical workflow, which are delay, connectors, and unclear stuff. And I'll show you a really simple one on this slide, which is for specifically for a diabetic patient. You can see it starts here with a patient with a diagnosis of diabetes identified, sees their primary care provider, and needs diabetes education. So this is a workflow for how you're giving diabetic patients their education needs in terms of how to inject stuff, how to take their medications, how to control their blood sugar, et cetera, et cetera. And again, you see the rectangles are the processes, such as patient is given an option. Is it a diabetes classes or a one-on-one with the nurse to learn about blood sugar monitoring in the middle, or referral to dietary services? And then you look at this diagram and it gives you a really nice overview of the workflow of how you're going to do things when the patient is physically in your clinic and needs all of these things done. I guess for those who have worked in their clinics and managed diabetic patients for years or months or a very long time, these can all be very natural or common sense to them. But sometimes when you're onboarding new people, or you have new people who you want to help work with this, or if you want to optimize your workflow, you need to have things mapped. This is an example flowchart then of data from the data side. So again, here you saw physical processes, which is a patient moves from one process to another. This one is a data flow chart for how you're reporting your clinical quality measures. For example, in this case, how many percent of diabetic patients are controlling their HbA1c levels. And you can see there's a reporting deadline at the top left. Does your practice have a registry? Do you have a data manager who's doing the data reporting? If your data manager is new and doesn't know what to do, there's a delay. And then you continue on from left to right in a sequence. And then you have the reports are pre-made and all of these delays and all these other stuff before you end up at the final piece of the puzzle, which is when the data manager sends the report to CMS for that quality measure. Now, to be effective in helping you create a map or redesign a workflow that you're seeing in your clinics, I'm sure when you guys are going through your patients with diabetes or with chronic diseases, I'm sure some of you have some ideas deep inside, like, hey, you know what, we can do this faster, or hey, why are we doing this? It's such a waste of time. And that's what this concept is all about. It's trying to optimize your time, identifying the waste by using a map. So when you're designing a map, you need people with a good working knowledge of your clinic's EHR and information technology systems, your health IT systems. Because again, physical processes go hand in hand with data processes. And a good way of mapping very complex processes, for example, maybe you're handling your diabetic patients or going through a lot of different physical processes, it's very good that the person mapping can actually observe the process in action. This can take maybe a day, 2 days, 3 days, or whatnot for your person to map this. But again, direct observation is always best. And if you have the data to back it up, for example, if you have a person checking the time for each process, how long each process takes to complete, then that would be even better. Again, the rule of the thumb is when mapping a process, the person who controls the process controls the pen. So for example, your MA is doing a process wherein they're checking your diabetic patient's blood sugar, then the MA should be the one filling up or doing the mapping for what he or she is doing. And it's the same thing for the nurse, the same thing for the PA, and the same thing for the physician. And then there's two really quick flow charts you can do. There's this high-level flow chart on the top. It's really a top IO bird's eye view. Patient arrives, registers, seen by a doctor, pays, and then leaves. That's it. But what we would want is a more detailed flow chart, right? The person arrives, goes to records, is the clerk there, is a medical officer, or is a physician available, and then there you go. So this is just a very simple example of a detailed flow chart. But that's, again, these are for physical flow charts. This doesn't take into consideration data processes. So I'm going to show you what we call a value stream map. What is a value stream map? It's very different. And these are just really quick symbols that I want you to focus on. First is this one. It looks like a factory, but it's not. It's a customer. So think of it as your patient. Sorry. Dedicated process where you can see this some symbol right here, which means one full-time employee. Let's go on to the right side right now with the blue icons. This triangle right here would be an inventory. So for example, if you want to track PPEs, masks, insulin stock, syringes, medication stock, stuff like that. So this can really be big. You can create a really big map with these things. I know these symbols are all new to you guys, but bear with me because I'm going to show you guys examples. Take note of these arrows. There's this straight arrow, which is which has manual information. This is when information is transmitted manually, or for when you're typing something in the EMR. On the other hand, this is this lightning bolt, Harry Potter type of arrow, where it's automatic or electronic information, such as when data flows automatically from one place to another, right? And then lastly, on the right side here is what's called a Kaizen burst. It's when you have identified places where things can be optimized. And then last but not the least, an operator, which means this is one FTE or one full-time employee, like a nurse, MA, PA, physician, that's doing the process for you. And last but not the least, the timeline showing value adding and non-value adding processes. Let's get into the nitty-gritty, shall we? This looks very complex, I'm sure, especially if it's your first time looking at a value stream map. The point here is that data flow and process flow overlapping together. It's very complex, and you need a way to do this. So let's try to dissect this in the context of a diabetic patient's case. So your patient is right here, the one in blue. And there are phone calls to external providers. There are phone calls to reception. There's phone calls to another receptionist from a different health center. So you see there's a lot of data flow and there's a lot of information flow that's manual and not manual. Take note that this is read from kind of left to right. You can see this arrow that I'm pointing out right now. There's this strange arrow going up and going down. That's time arrows. It's a way to indicate if the patient is waiting or not. So in this case, the patient is waiting at reception in this part of the map. And then going more and more to the right, you can see the numbers are fluctuating. And this number is actually a ratio of how much time the patient is spending, for example, here in check-in, versus the time that your full-time employee is taking for each patient. So in this case, the higher the number, the higher the value. So let's move on to something easier to look at. So again, this is read from left to right. This is a very simple value stream map. Your diabetic patient arrives here, signs in. You can see for some there's a very automatic way of signing in. And then the diamond again is a wait time indicator. It goes to registration, and then goes to intake, exam room, checkout, and depart. And you can see that the EMR, there's the EMR part, or there's always data flow in each of these different operations. And what I want to direct your attention to is the one here in the bottom, which is what's non-value added and what's value added. This is the amount of time a patient spends, or the amount of time that you, the provider, are actually adding value to the time that you're using. So a good example would be a patient is waiting for an exam room and they're just sitting there. That time is not value adding. And so how can you add value to that time? You can add value by maybe giving them something to read or something to watch that's related to their care, their diabetes care. And you can see that this is a very involved process where you have to measure, you have to look at time, and you have to measure time. And we're not telling you to do this. You can do estimates, but if you want to really dive in and really optimize your time in your clinics, then you really have to do a process like this. Um, this is again another example of something that's external or outside. Right now, we're during COVID times, right? There was a lot of shortages for PPEs. How come we're using this mask? Well, I don't have PPEs. There are ways to map that also from a manufacturing perspective. So what you're seeing right now is drug dispensaries, and what are the processes for getting drugs from the suppliers onto the stores, out to the dispensaries and stuff like that, and out to your outpatient clinics or to your patients. So I hope this is not information overload, but again, the point we're driving here is that time is important for each person. The time is important from your side. Is there physician getting burned out? Can we make some of the work that the PA, the nurse, or the PCP is doing? Can we offload those processes to some other people? And that getting that insight, some might have a feel of it, like, hey, maybe we could just give this work to assign this process or work to this person. But then if you want evidence or data to support those changes and initiatives, then you have to do mapping. And what you can see here in the bottom, again, you can see the total wait time and the total service time. The total wait time you see here for this is a comparison of 4 clinics. And you can see there it's slightly different. And you can see the service time here on Clinic 1G is 24 minutes. And the total wait time for patients is almost 4 hours. And I'm sure everyone has experienced this when they go to clinics and go to see their primary care physician or their specialist. And it's these wasted time that that you'll think about, how can you add value to these specific processes where there's a lot of wait time. Here's another way of displaying your value stream map. What are the value on the top here are the value adding activities such as registration, taking the vital signs, time spent with your provider, and setting up a next appointment. And what are the non-value adding activities that you're doing? Giving a patient waiting. There's again a patient waiting in this from left to right process. There's a handwriting an appointment provided to a patient when it can be electronic. Providing a manual list of medications to your patient instead of a printout, or fax machines, stuff like that. That when you think about it, you can eliminate that from the process. This is another value stream map I wanted to show you guys that shows the Kaizen burst. So again, reading this from left to right, your patient starts here, goes to registration. You can see there are 2 egg-looking stuff here, which means there are 2 people helping out with the registration. And you can see the utilization factor here, which is 13%. You can see that registration is around 7 minutes. The wait time is 7 minutes. And then you can go from left to right. This is a workflow for optimizing patient flow for a hemophilia clinic and using this value stream map methodology. And they can see that there are delays in documentation in this specific health IT system they call WAPS. Here, the provider, the patient is unaware, or the people are unaware that the provider is ready to take in the patient. So those are value time that's wasted. Unorganized lab times, if the patient came in and the labs are not there yet, or the person can't find the lab. Again, unaware if the provider is ready to take the patient or not. It's a value wasted time. So they use this and use this value stream map and optimize their workflow in their hemophilia clinic. I'm on kind of a couple more examples of value stream mapping. Again, this is a very simple, quick and dirty way of doing this without the symbols. When they started, so this is this restructuring of a diabetes diabetes day center. They used a lean methodology in Ireland, where they applied value stream mapping for when they were transitioning from one electronic health record and patient management system to another. And their old system is this PAS and patient file system. And they were trying to transition to this diamond software system, as they call it. And you can see that there are different information processes that go, again, from the patient file, the old system, which duplicates the process to the new system. So there's a lot of wasted time. And then here, once they said that the patient from start to finish should only take around 60 minutes. They mapped that, and they were able to transition to everything to their new software system, where they looked at the time it takes and the amount of full-time employees for each process: registration, seeing the nurse, seeing the doctor, retinal screening, foot screening, a dietitian, education follow-up. They all wrapped it up in the patients were able to do all of these within an hour because of their optimization. So we're going to transition out. I know this is a lot of information and data. We're going to transition to something that might not be as transparent to most, which is what's happening in the back end. There's, I think, a quick poll question to see if you guys are still with me. I know that's a lot, but again, what we were trying to drive there was that having a map really helps when you're optimizing your workflows, not just your data workflows, but also your physical processes. So the question is, what is your opinion on you or your team's overall understanding of the back end of healthcare data, like healthcare standard terminologies, common data models or elements, stuff like that? You can see this funny cartoon here where you, as the user of these interface of the software, you can see the nice pretty mermaid or the good food, but the back end is that big dragon or the mess in the kitchen. And the polling is ended. And most of you guys, thank you very much for being honest, are somewhat knowledgeable. You've touched base with some of these standards because of the reporting of these quality measures, or because you as a clinicians, you are doing coding or putting the billing code for your patients. So there's always this treasure hunt about where's the data, and that's where we start in the beginning. It's all about the data. Just a really quick, just to wrap up what's happening in the back. If you're going to try to define, if you want your clinical manager or your clinical data manager to do all of that work, that's completely fine. But you as clinicians who are doing the frontline work for your diabetic patients, it's also important to know how this data is defined in the computers. And there's a lot of free text. Providers type a lot of things. If you have a dot phrases or smart phrases, you know that all of these texts will go to your electronic health record system. What you don't know is that all of these concepts on your free text, non-structured information that you're producing in the EMR can be understood by your software in different ways. And this usually gets lost for end users because they don't care. They think that your EHR is doing all of the work, but it's interesting. It's important to know that these can be coded, and that's how you can extract data from your EHR. So this is SNOMED, Standard Nomenclature of Medicine. So you are all familiar with the billing standards here on the left: ICD, HCPCS, and CPT codes. There are these standard terminologies: SNOMED CT, LOINC for labs, MEDRA for pharma research, RX norm or NDC codes for medications. And then you have this on the right, which are your EHR vendors. And maybe some of you guys have encountered or are currently using these things. And the difficulty with data is that these EHR vendors sometimes do not support all of these standard terminologies, or they use their proprietary code systems that are not interoperable with health information exchanges, disease registries, diabetes registries, stuff like that. And there's going to be more work that happens. And maybe some of you guys are familiar with what's called data mapping, where, for example, diabetes concepts in Epic systems are one code, and you have to map it to an ICD code that's defined in the clinical quality measure. And that takes a lot of time to do mapping, especially for complex submissions. Diabetic patients who receive eye care, for example, or kidney care, those have different CPT or ICD-10 codes, or again, proprietary codes that your vendor is using that registries and other sort of health information exchanges won't be able to understand. Um, so you would, for those who are more interested in what happens in the back end, or if you're extracting data and submitting it to quality measures, why are some data missing? And that's because a lot of the times it's lack of time or it's a workflow problem. And that's because it might be because some processes are dumped into one person, and that person is carrying most of the burden, and some workers may help with taking care of some of those processes, make barring any legal problems with that. For example, during COVID right now, we know that MAs, PAs, nurses were covering a lot of other work that's not traditionally their work, and that's because the workflow, the amount of work increased. So there's these three very simple lean concepts. These are actually in Japanese. This is muda, mura, and muri. Muda means you're wasting time or you're wasting activities. So the best way to counter waste is determining the time that data is most easily gathered or captured. So when you're doing surveys, when you're trying to collect data from your patients, you don't waste your time sitting in the waiting room. You can use that waiting room time to get data from them or to push educational material to them and to teach them. Mura, on the other hand, is an imbalance where one person is doing a bulk of one specific work where their activities can be better optimized or used for other value-adding activities. An example of this would be, again, for physicians or nurses doing documentation. How they do to counter this was to use encoders or abstractors or transcribers. So you see nurses, NPs, and physicians talking to used to record their voices so that this can be transcribed by a third-party service. And there's Muri, which is this is too much, and people get overburdened, and productivity and optimization decreases. And so knowing all those concepts, when you create your value stream map, then you can see these imbalances using time, using these what you saw earlier with how you overlay physical activities with data activities, and seeing how each person's time can be optimized by looking at how much time each process are taking. And it goes back again to getting that data, reporting that data, understanding the data, and acting on that data. Last but not the least is a lean concept called Kaizen. You don't have to get this perfect the first time. You just have to try it. You have to try to apply it throughout the patient's journey, from pre-registration all the way to ending the billing process. And we want you guys to learn Kaizen and all of these lean methodologies and mapping is because the future will produce more data. The future will produce more workflows, especially with the exponential amount of data we're producing every year. Genomic data will eventually come, outcomes data, biometrics data. So you can imagine your type 1 diabetic patients are pushing all of this data to your electronic health record system on a daily basis. And who looks at that data? Is it the physician? Is it the MA? Is it the PA? Is it the nurse? There's consumer data and social data, and all of this data will be eventually pushed to you to give better care for the future. And the ecosystem of human health data is growing by the year. So making sure that we have enough time to optimize our time when doing all of these things are critical as we move on to the future. So I guess there's a lot to take. Again, thank you for sticking with me, and I know we have about 10 minutes before 4, opening the floor to questions.
Thank you, Dr. Lee. We'll now open up the chat. Please type in your questions into the chat box or raise your hands if you'd like to ask any questions. I think I will get started with one question. Raymond, what are your recommendations in reviewing patient charts who have diabetes? What are some steps that need to be made to identify these ways?
I'll defer to Julia for that question.
I was going to say, so one of the precepts that we try to emphasize is first understand what the action is that would add value, or the information that would add value. And it's perfectly fine if you start by abstracting that by a person, right? A person actually can sort of quickly tell you, where is the information? How often is the information correct? They have other contexts that they can use to let you know sort of how effective the process is now. And they can also say, what would their user requirements be? What would help them to do it more quickly? Well, maybe they would like to see a dashboard. Maybe they would like to see a chart or a graph. Maybe they would like an alert or a reminder. So it's actually not a bad strategy to have some real users take on the activity of doing it by hand to say, well, having done it by hand a bunch of times, I would like for it to be automatic. And these are the things that I definitely would need to see or have the opportunity to do to make it much more efficient. So I would say, you know, it's almost like you then automate yourself out of the process once you define the process based on the primary user's requirements.
Thank you. Does anyone else have any questions from participants? I'm looking down the list to see if there's anyone who raised their hand. We don't have any right now.
And I'll add one more comment to that last example, keeping in mind that the user you first think about might not be the only person who's a stakeholder in that activity. So thinking about how would the MA do it if we were giving them the chance, or how would the nurse do it? That actually activity of multiple people independently trying to go after a specific target would actually give you sort of more diverse options, and maybe allow you to do some innovation that you wouldn't come up with if you just told the provider to go in and do it themselves alone.
I have another, we have a question in the box. The question is, how would you suggest a clinic get started? It feels hard right now to get out of survival mode and transition into proactive mode.
So I'll let Ray answer this as well, because I think diversity of opinion may yield multiple good answers. I would start just by looking at the data, right? Because this way, not only can you offload that sort of onto staff that maybe aren't on the front lines right now, but also you can sort of get, you know, a snapshot of where are you as an organization in terms of how easy getting that data is, how accurate does that data seem. All of that can happen without any interruptions to regular care. So I would say doing the background research is probably the best place to start. And then you just have to make a plan to say, who are the critical stakeholders? And let's bring them all together and have one discussion about the, you know, deficiencies and, you know, the successes in the way we manage this now. And if there's a lot of enthusiasm about correcting a deficiency, or you're hearing that actually you have a lot to gain from making those changes, you'll be motivated and you'll be willing to sort of free up the extra time. Because if you discover that, you know, every person on your team is spending 5 extra minutes a week on each diabetes patient, that's a lot of free time that you're going to get back if you can eliminate that, right?
Yes, I could have answered that in the chat too. Just to reiterate, I know right now it's survival mode. COVID is happening. You know, everything. A lot of things are happening. What you can do, Amanda, and for the rest of everyone here in this this webinar would be just to write down your idea. Get with your usually managers or how this traditionally done is through instinct. Like, oh, I feel like this is suboptimal. I feel like this is something I can optimize. This is something I can improve. Right now, you can just write it down on a piece of paper, right, back of the envelope, um, just so you don't forget. And then try to, on your spare time, maybe when doing lunch or having a snack, just draw your idea. It doesn't have to be using the icons that I presented. It's just putting your idea down and writing it down and mapping it down and drawing it. And then when the time comes where, we're not in survival mode, we can actually start getting some time to start and impact the change in your health center. That's when you gather the evidence. That's when you create a formal workflow map. There are lots of tools online that are free to help you create these process maps. You can start with a process map, and then once it gets bigger and bigger, that, oh, you know what, the data comes in here, the data comes out here. That's when you can start creating a value stream map where you can show the decision makers in your healthcare clinics, look, this is what's happening. Look at these parts, and these are the places where we can do some Kaizen, or we can actually do improvements for create value to not just your patients, but also to give everyone more time to do more value adding things.
Yeah, and as part of Ray's idea, actually, it would be great to just tell everyone at your organization, hey, if you come up with a good idea, or if there's something that's really you think could be done a lot better, put it into an email and send it to this person, or write it on this bulletin board right here, or put it on our website in this, ideas for improvement link. Just establish to everyone that their ideas about that are valuable, and make sure that, as Ray said, you record that right at the moment that it's happening.
Yes, Lindsay, go ahead.
Yeah, very quick, because I know that we're running out of time, but this is part of the role of the HCCN coach assigned to Nevada. That we have worked with several centers here in Arizona, and now it's Nevada's turn. We have helped many centers to map out to like, if you're not sure about the idea, let's brainstorm about it. Let's meet together. That's why we are here. There are several clinical guidelines that we have helped create, for some of them. So please reach out to Rima, send her an email, and we can definitely, support you with this. And if we need to bring Dr. Yu and Dr. Skapik, later in the picture, we will be happy to do it.
That is awesome. Thanks, Lindsay. Rima?
Yeah, thanks, Lindsay, for chiming that in. Definitely happy as an HCCN coach to support centers. But if anyone else has any questions, I think we will close today's webinar. We thank you both so much, Dr. Lee and Dr. Skapik, for joining us today. Thank you, everyone, for attending the webinar. If you have any further questions, please contact me at rnaik@nvpca.org. And once you leave today's webinar, you will receive a survey on the presentation, and we'd definitely appreciate if you can complete that survey. And we also have a question on there for follow-up discussions on diabetes too. So please make sure you fill it out. That way we can follow up with you for that. With that said, thank you for joining us today, and have a great rest of your day. On behalf of the Nevada Primary Care Association and the HCCN, thank you so much.